Why isn't mechanical CPR doing better? I want to look at a paper that looks at the use of mechanical CPR in rural services and how its use and performance there may be contributing to why it's not doing better. A lot of people sing the praises of mechanical CPR. It never gets tired. It's a force multiplier. It performs perfect compressions. Let me critique that last sentence first. No mechanical CPR performs perfect compressions. The piston of the Lucas may be compressing perfectly. The band of the autopulse may be pulling in perfectly, but unless those devices are compressing the left ventricle, there is adequate cardiac output and adequate coronary perfusion pressure, then that compression is not perfect. Regardless, we haven't seen an improvement in neurologically intact survival with the use of mechanical CPR in the data. There may be pockets here and there across the country who have seen improvement with its use, but overall there has been no improvement in survival. This paper looked at the use of mechanical CPR in rural agencies during the year 2017 and 2019. It was almost 600 patients, and the data was pulled from NEMSIS. There was no improvement in survival with the use of mechanical CPR with these rural agencies. That was expected. That's not surprising. It's consistent with other data. Here is the two takeaways that were significant from this paper. There were significant delays in time to first defibrillation and time to first epinephrine with the use of mechanical CPR in rural agencies. This isn't a small thing. Your first defibrillation is your most important defibrillation. And as a service, you should be tracking time to first defibrillation as one of your most important metrics. Time to first epinephrine is also important, and I know that the Paramedic 2 trial demonstrated that administration of epinephrine, according to the way that the AHA recommends, may be associated with lower rates of neurologically intact survival. But most of the patients in that study received epinephrine the first time at the 20-minute mark. So it still may infer a benefit the earlier that you give it. So giving it as early as possible is important. The data from the study obviously infers that when crews are arriving, they are prioritizing mechanical CPR over that first defibrillation. This is not when we place mechanical CPR. When you arrive at the scene of a cardiac arrest, your priorities are performing high-quality manual CPR and getting that patient ready for that first defibrillation. And when you get to that rhythm check, you defibrillate immediately. You don't place mechanical CPR first. Those first couple of minutes after EMS arrives at a code are where patients live or die, and prioritizing utilities over performance has a potential to steer that chance of living or dying in the wrong direction and having a bad outcome.